to you your presenter for today. And Rosemary, she's a public health nurse who has been nursing since 1999 and working in public health for over 13 years. She leads the Perinatal Mental Health and Women Abuse Prevention BPG for the Thunder Bay District Health Unit, and she is currently working on a master's in health management at McMaster University. And so for those of you who are not familiar, if she were to say Best Practice Spotlight Organization or BPSO, it refers to a program that we have at RNEO that involves healthcare as well as academic organizations that are selected through RNEO by a request for proposal process to implement as well as evaluate the impact of RNEO's best practice guidelines. So it is quite a dynamic partnership, and the focus is on making a positive impact on patient care through evidence-based practice. So now I'm going to pass the presenter ball to Rosemary so that she can start her presentation.
Okay, thank you, Grace, for the introduction. Again, my name is Rosemary Scoffage, and I am from the Thunder Bay District Health Unit. So when I first signed on to present this webinar earlier this year, I was in a professional practice lead position. However, I've now returned to my public health nurse maternal child role. And although I don't consider myself an expert in perinatal mental health, I have been working to develop capacity for the topic since 2013. And I'm happy to share our experience in implementing this guideline. And I just wanted to say that our health unit started our BPG journey in 2008 and received our Best Practice Spotlight Organization designation in 2011. And so before I begin my presentation, it's important for me to acknowledge that the land on which I stand and on which my health unit resides is the traditional Indigenous land of Anishinaabe people, as well as I would like to recognize the Métis people in our community. Oh, just gonna have to. Oh, I got thrown out here. Hang on here from the beginning. Oh, is it working? There we go. Okay. So I know that many of you who are joining us today are from different areas of the province, and each city or community is very unique regarding availability of resources and issues you may have, but I'll give a quick summary about our region so we have an understanding of the community in which we're implementing this best practice guideline. So Thunder Bay is located at the head of Lake Superior. It is known for its rugged beauty, its cold winters, and beautiful but short summers. We're the largest city in Northwestern Ontario with a population of around 109,000, but the entire district in which we serve is about 146,000. On average, we have around 1,500 births per year, and we have a growing new immigrant and large Indigenous population. And our community has many positive attributes. However, we are greatly impacted by the social determinants of health. For example, from a health perspective, we have a physician shortage, we lack family doctors and specialists, and we have high rates of chronic disease and mental health and addiction challenges. And we do have one of the highest youth crime rates in the country, as well as violence against women is a significant concern in our city. Also important to mention, I apologize, someone's phoning me. Also important to mention is that we have high rates of maternal mental health challenges. For example, in 2018, 39.9% of the women who were pregnant in our district had a mental health concern in pregnancy, whereas the provincial average was 19.2%, which is why implementing this best practice guideline is so valuable to our community. So for the next 20 minutes, I'm going to talk about how our health unit has implemented the assessment and interventions for perinatal depression best practice guideline, with specific focus on the practice and educational recommendations that we chose. You can expect to hear how our health unit built capacity around perinatal mental health with a focus on problem solving, addressing gaps, facilitation of resources, and providing education for service providers on maternal mental health so that we can best meet the needs of women and families who are having difficulties. I would like to mention that none of this work is done in isolation. Over the years, there has been collaboration with provincial partners, academics, community agencies, and other internal public health programs. We all need to do more with a little less these days. I feel that this is a statement, that the statement is a good representation of what is expected of us in these times, which is why capacity building is so important for our communities. So what exactly is capacity building? Well, the United Nations defines capacity building as a conceptual approach that helps to understand the obstacles that inhibit us and then focus on the process of developing and strengthening the skills, instincts, abilities, practices, and resources that organizations and communities need to survive, adapt, and thrive in a fast-changing world. So an essential ingredient in capacity building is transformation that is generated and sustained over time. So how do we ensure sustainability? Well, by having practices, commitments, or indicators in place to achieve measurable results and keep the issue on everyone's agenda. So this slide has the different initiatives that we've done locally to build capacity in our community for perinatal mental health. I'll highlight just a few right now because many of them I'll elaborate further on as I talk about the guideline implementation. So one key activity that I would like to highlight and something that we had good success with, we have a good relationship with the Women and Children's Lead at our local acute care hospital. And this connection allowed us to do an in-service for, well, it was a quick presentation for our maternal newborn and NICU staff, okay? And what we did was we did an in-service on their coffee breaks where we provided some food and the staff came and listened to our presentation and took some resources. So we found that this was a valuable opportunity as the nurses left with an understanding or an update of what was available in the community so that they could inform the women that they were caring for and soon would be discharging home to the community. Another initiative was we hosted a breakfast with Dr. Cindy Lee Dennis as a distinguished speaker. And we got the funds for that. It was a partnership with our local university and many of the universities in Ontario have this opportunity because it's a professional development opportunity for faculty. As part of the requirements for the funding, Dr. Dennis spoke at Lakehead University to faculty on her perinatal research and then also at a breakfast that we organized in the community. And we also had local families speak and share their experiences with postpartum depression. Also, to build capacity for the topic of perinatal mental health, we started with focusing on the baby blues. And we created this mirror decal, which we asked the local hospital to place on all the mirrors in the washrooms on the maternal newborn and NIC units in the hope that it would be a conversation starter for families with their nurses or their care providers. And there was also a rack card, which is like a thick bookmark of information that complemented the decal and it had information that could be provided to families upon discharge. So before implementing any of the best practice guidelines, it's recommended that internally you review your policies and procedures in relation to the guideline and identify gaps and opportunities for topic development and protocols. So we actually started this process a long time ago, which began with a situational assessment, which involved looking at trends from the literature, a scan of the environment, and stakeholder perspectives on perinatal mental health in our community. The assessment results gave us a baseline for change and rationale to move forward with next steps. So the stakeholders that gave feedback were service provider agencies who interacted with women in varied capacities. And so some examples of the stakeholders were early years providers, a women's legal clinic, social service providers, and midwifery practices. And they highlighted what they felt was missing in our community around maternal mental health. So some examples of what they highlighted were the importance for women to access peer support or have a network of peers. Also highlighted was the need for timely access to counseling and a separate way into the system, considering the risk of missed intervention or delayed treatment on maternal health and also on infant development. And then the importance of education came through and the particular need for service provider education and public awareness. And we were very interested in moving forward with a public awareness campaign, but we sort of put the brakes on because we recognize that any type of awareness raising requires resources to support the women who'd come forward because of the information that we'd be advertising. So as a health unit, we first needed to focus on resource development and community capacity building for perinatal mental health before we could launch a health communication campaign, so that we had something to offer women as well as educated service providers to assist those families. Something else that was shared from the stakeholders and were also common concerns voiced in the community through our collaborative work were that there were consistent beliefs and values expressed by the women they were seeing. For example, women were saying that they wanted to be with other women who were feeling the same way they were, and that they were also having similar challenges. And when they attended different programs, they felt judgment in their parenting, and there was a belief and fear that if they shared their mental health challenges, that there would be child protection intervention and a risk of losing their baby. These same local themes are also consistent themes in perinatal mental health research as barriers to help seeking in perinatal anxiety and depression. Now, since we had done the situational assessment, we were in a good position to implement the perinatal depression BPG, as many of the recommendations in the new BPG that was released in 2018 aligned with what we were working towards in our organization and could help to address the gaps and issues that were noted in our community. So the first practice recommendation that aligned was 1.1, which is to routinely screen for risk of perinatal depression using a valid tool as part of prenatal and postpartum care. So our HBHC nurses were already screening women they were seeing prenatally and in the postpartum, but the recommendation helped the team to update their perinatal pathway. The second practice recommendation, 2.4, encouraging symptomatic people to seek support, is included in our updated pathway. And it also helps staff to understand the needs of women, for example, her information needs, mental health needs, and what resources she has or requires access to. As well as with all our interactions with families and our community partners, we encourage individuals and families to seek support, and we try to promote options, recognizing that there's not a one-size-fits-all approach for mental health. And then for 2.7, for providing or facilitating access to psychotherapies recommendation, you may recall in the situation assessment findings, peer support and timely access to counseling and a separate entry to services was highlighted as needed in our community. So our health unit on our own, and then later in partnership with community agencies, worked to address these identified gaps. So I can say that we did work for a while to help facilitate resource development for maternal mental health as we look for opportunities for resources in our community. It was challenging, but as we work to build capacity for perinatal mental health and implement the practice recommendations, there were some key lessons learned that are worth sharing. So starting with the important role of champions, and for this slide, I'm not specifically talking about BPG champions, although they're great resources, but instead key people that you want to engage. So if you're looking to partner or help facilitate resources for perinatal mental health, I recommend that you find a champion that is passionate about perinatal mental health. So if you look up what a champion is, you'll find the description of a champion being the driving force of organizational change, leading their teams through the change towards innovation. So I encourage you to think of why particular agencies offer the care, programs, and services that they do. It can be because they're mandated to, like we are in public health through our Ontario Public Health Standards, or organizations may provide the programs and services that they do because, well, they're funded to, but it can also be because of evidence, local need, or a passionate individual that brought the topic to the attention of decision makers, for example, board of directors. We had success locally because we were able to eventually find a few key essential champions within certain organizations that advocated for maternal mental health in our community. Best practices, the BPG is a helpful resource, but we also reached out to other agencies, or in our case, other health units, who were also doing what we were trying to achieve, which was very valuable. There were other health units who were already offering perinatal peer support and group therapy, and we reached out to those topic experts at those health units to see if they'd be willing to share resources. Specifically, we ended up getting information on the format of the groups they ran, therapy models they were using, who they partnered with, the length of the group, referral processes, and the content and topics shared. Also, it was good to learn if there was childcare offered, food provided, or was there help provided for transportation. And finally, were there any lessons learned that they were willing to share, or what they might do different if they were going to implement again? Another lesson learned was that if you're not having luck engaging the traditional individuals or organizations you're hoping to work with, then look for those new partnerships. So for perinatal mental health, some partnerships that we feel are worth exploring are collaborations with early years professionals, academics, mental health clinicians, the acute care health sector, prenatal and postnatal care providers, and the violence against women sector, and as well as child protection agencies and social service providers. Locally, we had good success in partnering with Lakehead University on a number of projects because there were academics in the School of Nursing and Psychology programs that were interested, and we applied for a number of research grants for funding, and we were successful in getting the funding and building local evidence on the effectiveness of group therapy and peer support. As well, our agency added perinatal mental health to our yearly work plans, where we set goals, objectives, and outcome indicators. And with that planning, we also allocated money in our operational budget so that we had funds to work with for, so we're able to work towards what we were trying to achieve with that money. As well, I recognize that, there can be fiscal restraints and not everybody has access to a funding pot. But I also can say it is amazing to see what can be accomplished when invested organizations get together to collaborate. Sometimes you don't need money to make great things happen, and you can share resources or donate time. And if the topic is of interest, many agencies set money aside for professional development and training and may be willing to send staff to an event you're considering hosting, even if there's a fee to attend. So circling back to the practice education recommendation 3.2 and the gaps identified specifically around timely access to service and that separate entry into the counseling system piece, we worked on a collaborative research project led by Dr. Amanda Moranzan from Lakehead University, which resulted in positive findings locally and that were recognized by a local mental health organization, who then took that information and agreed to run a permanent perinatal mental health difficulties group. And it has been sustainable, which I'm quite pleased about because of those agency champions. And it continues to run virtually now. The group is unique and different than other mental health groups, as the women who are referred or they can self-refer are triaged straight to the clinical psychologist, Dr. Missy Titero, who then contacts the women to assess, and then she also facilitates the group. So she's built that relationship with them. Moving on to the education recommendations we implemented, 3.2 to be specific, which states to participate in ongoing professional development to enhance knowledge and skills in mental health services and supports for perinatal depression. So we did this for our own staff, but we also wanted to build that capacity in the community. So we looked for occasions to provide education opportunities to people in our community. So the funding I'd mentioned on the previous slide that we received in collaboration with the community partners that was around the group therapy, also allowed us to do other things. So for example, the same funds helped us to train a variety of service providers, as well as bring some distinguished speakers to Thunder Bay to speak on perinatal mental health. And then the events we hosted with the speakers allowed us to disseminate our research findings locally, and more broadly allowed the lead researchers as well to share at academic conferences. So in our community, we do have a good and beneficial working relationship with different organizations that are interested in improving child health. So earlier I mentioned the perceptions and fearfulness of child protection involvement by women who were having mental health difficulties. So we thought that a partnership aimed at educating and capacity building service providers, particularly child welfare workers, seemed like a good next step. So we worked with our Thunder Bay Infant Response Plan Community Committee as a collaborative community partnership to plan a full day perinatal mental health workshop. We had an elder open the workshop, and our keynote speaker was Jamie Charlebois, who's the perinatal mood disorder coordinator at Aurelia's Soldiers Memorial Hospital. And we hosted an entire day workshop. And this slide has the topics that we covered. So we looked at definitions, prevalence, risk factors, and impacts, and then how to engage and intervene. We talked about the screening, treatment, resource, and pathways. And then we also, we did some table work. So we had different scenarios that service providers may encounter and what that might look like for them. And then also it gave us a chance to talk about what we had to offer in our community. So who attended? We actually had a really good turnout. from different areas and organizations, with 93 people attending. So you can see the breakdown of where they came from on this pie chart, with child protection most represented, then acute care, which the staff was nursing, social work, and midwives. Then we had public health professionals, mental health, the early years professionals, and then finally we just had one participant from a local women's domestic violence shelter. So at the end of the day, we had forwarded on an electronic evaluation as well as a certificate of attendance. And when we looked at the summary of feedback, participants reported that they learned new information, and 100% of the participants said that they would like more information on the topic in the future. There was also a long answer option to add comments, which I captured on this next slide. So when we asked further if there was anything else that the attendees wanted to say, we received comments about being pleased that we included Indigenous content. There were positive comments about wanting to keep the conversation going around perinatal mental health. And also there were some suggestions for us to improve on. For example, there were comments about the amount of information being too ambitious, wishing that they had more time for the table work, and that the length of the day was too long. Also, one comment stood out about wanting information and validation on the difficulties when working with concurrent disorders in a homeless and pregnant population. So this past year, for some next steps, we had planned to go back and do some further evaluation with the participants of the workshop in May, which was 1 year after. We had planned to have some focus groups with some of the workshop participants to see how they were using the information learned from the workshop in their interactions with families, and were there any practice or organization policy changes as a result of the training, considering that there were some decision makers from different agencies that had attended as well. Also, we wanted to know how we can further support professionals and what additional information they felt they needed to keep the topic on everyone's agenda. So that's that sustainability piece we talked about. But because of the pandemic and our responsibilities for the case and contact management of COVID, the evaluation piece and next steps will have to wait a little bit longer. And then we do measure evaluation outcomes of the BPG recommendations, where we track education and training on the topic. And we closely work with the mental health clinical psychologist who facilitates the group therapy here in Thunder Bay to monitor the number of referrals to the group, the number of women that actually attend. And then also we ask the women for feedback. So here are 2 quotes from women who gave permission to share their testimonials. "It was so tough to go the first day, but once I was there, it was easy to come back. I wish I would have attended sooner." And then listening to the other women's stories made me realize that I'm not alone. The intense feelings you have are so common. And then in closing, this is a list of different individuals and organizations that we've worked with. So thank you very much. Are there any questions?
Oh, excellent. Thank you very much, Rosemary, for that very meaningful presentation. I do appreciate that you covered capacity building and doing that through education and through networking and through a lot of your initiatives, and the importance of sustainability, especially during these times when I'm sure it's especially needed. So thank you very much. Is there any questions from anyone in the audience in regard to the presentation, or anything you'd like to ask Rosemary in terms of her expertise? Oh, there is one question here. Christina is asking, how have your strategies changed in response to the pandemic?
Well, how have they changed? We were hoping to look at stigma in our community, but I feel like that is such a huge piece, and it would involve multiple different organizations and agencies. So it's sadly it's on hold right now just because of public health. Our focus is case and contact management, but it's unfortunate because with mental health, this is when people need us most. So our strategies really haven't progressed at this point in time.
Okay. And I mean, yeah, the pandemic has really impacted the healthcare sector to different degrees, depending on where you are. And Christina is also following up and said, are there any professional development training or courses that you would recommend for professionals looking to enhance their skills related to PMH? And that's from Christine, and she's a midwife in Hamilton.
Mm-hmm. Well, interpersonal therapy, there are different opportunities to learn more about that therapy. There's actually an institute. Um, the, if you could learn more, I feel like that would be valuable in an individual setting or a group setting. And you could just Google that as well.
Okay, great. Thank you so much. And Christina Canton, she was following up to your comment saying, yes, stigma is so important to address. And she was saying, excellent presentation and thank you. Cassandra is asking a question. What screening tool are you using for prenatal depression?
We're using the Edinburgh.
Okay. And Cassandra, did you want to know anything else about that specific tool? Just let me know. And if there's any other questions, we do have about 10, 15 minutes to be able to field any questions or any comments that you have. I mean, while you're thinking about that, oh, Cassandra is saying, are you also using that tool for postnatal?
Yes.
Okay, there you go.
Sorry.
Short and sweet.
Yeah.
Okay, thank you, Rosemary. Okay, and she's saying thank you as well. I do appreciate that there was a networking and amongst the public health units in regard to the perinatal depression. I was wondering if there was any network amongst the mom groups from different public health units, and also in terms of the healthcare professionals networking with each other and supporting each other.
Well, for moms, I would say no. I feel like it would be wonderful if, some of the women that were feeling better, right? Because we know women that when they get the help they need, the earlier intervention is better, that they seem to feel better more quickly. It'd be wonderful. We've tried to have a few women sort of be our champions and connect with other women and create a larger network, but it never seems to gain any momentum. I would say that we've had a couple initiatives like provincially that there was some Trillium funding, for example. There was a PPMD strategy that was started by, I think it was in Northeastland. It was led by a lady named Linda Rankin, and then our funding fizzled, and it sort of seems to be one-offs. We'll gain some momentum. We'll connect with some different professionals across the province, and then we sort of lose connection, and it's almost like you have to rebuild and restart all the time. But I do feel one good thing that has come from COVID is the use of technology and being able to offer more resources virtually and reach more families and women. So I think you'll see quite a bit happening across the province with regards to virtual counseling for perinatal anxiety and depression. I know there's a couple of things in the works. And if anybody has any questions around that, they can connect with me after. I don't know if I answered the question.
No, that's really good. Oh, that's really good. I was just curious about that, and appreciate that there's challenges with being able to with sustainability, and you really need those super connectors and the champions within those networks to keep it going. There are some other questions. Christine was asking again, is there a specific time in pregnancy where you use the Edinburgh? And what is the uptake of providers in doing Edinburgh prenatally with their clients' patients, or is this something that is done through public health outreach?
Well, I know and that's the thing with public health, our nurses tend to see those that are considered high risk, right? So we don't get to reach everybody. It's only those that we come into contact with. But I know that the best practice is to screen at least once prenatally and then in the postpartum. So that's what we follow. I can't speak for service providers across the province. I do feel we need to do a better job overall. I mean, I know locally, but I don't know what happens in other communities.
Okay, fair enough, fair enough. Brenda is asking, do you have any online support groups that you would recommend for women for perinatal anxiety and depression?
I think it depends on the community you're from, because some were meeting locally and then some moved to online formats, right? When as of March, and like we do have our group therapy has moved online, and then I had mentioned there was some opportunities coming. but they're more formal. They're more formalized in that they are centered around CBT or IPT. And then often because of that, there may be research associated with that. So that's all I probably could comment on that. There is one network that I could connect you with. If you want to connect with me after, I can send you the link to it. I just don't have it with me at the moment.
Okay, no problem. I believe, Rosemary, she had agreed to share her contact information and email address with everyone. So we will also include that when we email you and follow up in regard to the evaluation. Let's see here. Can you talk more about the strategies for facilitating access to therapies? Can you share more information about the referral pathways and any insights into how providers in your community keep up to do with the services and supports available?
So in our community, the way it works is, I would think for general mental health referrals, it's probably similar from community to community, and that people are referred, and then they're sort of lumped all together, and they go through some decision making by the key people in those agencies, and they get triaged. So here, because we identified, we have high rates of maternal mental health difficulties, and we recognize how, important that first year with baby is, and in pregnancy, that pathway was important to have a direct pathway. So in our community, the physicians or nurse practitioners that refer formally, when they fill out a referral form online, we ask them to identify that they're seeking perinatal mental health support, and then it gets triaged right to the clinical psychologist that runs the group. But then it's, I find reach is hard in that even though we put the information out there, there's still physicians and care providers that still don't know about the group or don't really understand. So it's we really have to keep on the communication piece. Mm-hmm. And then we also have it where women can self-refer. Our Healthy Babies, Healthy Children nurses will refer to the group as well. And if I encounter women in the community that I've met, I also will let them know, and sometimes I'll flag them if they give me permission with the clinical psychologist. But it's to keep that, it's like a sustainability piece, really trying to stay on top of it.
Mm-hmm. Okay, no, thank you very much. And there's another comment here or question. Is any help for peri or postnatal anxiety due to COVID? Is there more incidence in anxiety these days?
I don't have a local stat. I would imagine it seems like everything mental health related, the statistics are higher. One thing I can say is it seems that does tend to be more of a focus on perinatal depression, and not as much out there for perinatal anxiety. But you might find the women that you work with, they may have perinatal anxiety, but then it ends up turning into depression because they're not coping or they're not managing well. So it would be wonderful to have more available to address anxiety as well as depression. But I don't have because my focus was capacity building for our community and our experience. I couldn't comment on a specific statistic, but I'm pretty sure they're much higher.
Okay, no worries. Is there somewhere credible where you would gain some of this information? Perhaps not. I don't know if you.
I do. I mean, because I'm public health, I do find the Public Health Ontario, the reproductive health and maternal mental health snapshots helpful. The challenge with that is that it's a bit it's delayed in that it's not always timely, the information that's posted, but the Born database is helpful.
Okay, thank you. And Brenna is asking, do you refer Indigenous clients to any programs available that are uniquely accessible to them?
Well, we do. There are Indigenous women that have been referred to a variety of services. I could speak specifically to the IPT group therapy that we run here. We haven't had that many women who identify as Indigenous come through, and again, around capacity building, we've worked with, we've presented and we've worked with some of the local Indigenous agencies to try to see maybe there'd be interest for them to partner and maybe offer a group specifically through their agencies. And because everybody is maxed, there wasn't interest necessarily, but they did make some suggestions for us around how we could make our group more interesting for Indigenous women. And so some suggestions that were made were around, and having it, first of all, to be drop-in childcare, which we already have. We do. Well, when we weren't meeting when we were meeting locally, we had childcare. We actually had food as well, but obviously, since it's moved to virtual, there isn't the childcare piece. So they also had mentioned incorporating a craft. There was a lot of great suggestions. However, we haven't been able to incorporate those. I feel like perhaps the best strategy would be to try to find an Indigenous champion to offer through one of the Indigenous organizations, because they already have a relationship developed with those families. But I feel like that's a next step. That's another opportunity.
Yes, definitely. I have Nancy here who has been responding to some of the participants as well. And just to let you know, in terms of a resource for anxiety or coping with anxiety, she was saying there's a great resource with women's mental health in BC as well. And she was talking about what they do in terms of the Edinburgh scale. And she's a nurse practitioner in the clinic. And so they do the first major prenatal and then at the well baby visits 3, 6, and 12 months. So just to give you some additional information there. Oh, she's a social worker in an NP clinic. My apologies, Nancy, but thank you very much for responding to some of the participants as well. And Christine is also saying, and she's not aware of any online group specific to perinatal mental health in Ontario. Postpartum Support International has online drop-in groups through the States. And she also runs an online postpartum peer support group. So there's additional information there. And
I just thought of two things, actually.
Yes.
So there is there's a group called Life with Baby. They have different chapters across Ontario. So that's something that you could look into for families. And then Women's College Hospital had an online group as well, but I think it only runs a few times a year. It's called, I'll have to look it up, but I know they have intakes that they run a couple times a year, and it's anxiety and depression. So again, that's something I could forward after if anybody was interested. I just don't have it on the tip of my tongue what the group is called.
No worries. No, that would be fantastic. Thanks so much, Rosemary. We do have a few more minutes before we close out to the webinar. I just had a question actually in regard to a lot of the virtual offerings online, networking, that kind of thing, in terms of equity and in terms of reach, and perhaps not everyone having access to internet or enough data to be able to sustain, for example, a 1-hour Zoom call or whatever it may be. Just wondering how you navigate that.
Well, I guess there's always phone support, but they'd have to be connected somehow. So most health units have Healthy Babies, Healthy Children programs, which those nurses are wonderful, and family home visitors are wonderful resources for families. So there's a connection there, and those nurses have lots of training. So that's one option. The phone support, if they don't, otherwise through formal therapy, I'm not sure if that's something that's doable, but again, perhaps if they had a connection with a care provider, that would be something that they could talk about.
Okay, excellent. I see that there's some more sharing happening in the chat box, so thank you so much. Just one last call out in terms of any questions, or else I think that we will wrap it up for today. And Rosemary, did you have any final comments or final last words?
No, thank you very much for all your questions and for the discussion today.
Yes, thank you very much, Rosemary, for sharing your expertise and your experiences, and specifically in the Thunder Bay area. And just to let you know, today's presentation and webinar recording will be posted on the RNAO website. And please, we continue to offer these champion webinars on a monthly basis. And we do look forward to your feedback in terms of various topics and future topics. And if you have any other questions, please contact Andrea Stubbs. She's the project lead for the Champions program at astubbs@rnao.ca. So thank you very much, everyone, for participating. Thank you very much, Rosemary, for presenting today, and we look forward to meeting all of you again in 1 month's time. So take care and have a great day.